Excellent. Thank you very much. So yeah, and the reason for that is that they actually do have a fairly marked improvement in their functioning and quality of life. So the next topic that I'd like to move to, which is a completely separate topic, and I'm sorry we don't have the pictures here. Actually, why don't we get back to that, because God, I've got such cool slides. It's pity not to be able to show them. Give them a second. I tell you what, I'm going to go to the hepatorenal thing, because that's actually got a something that you can follow without necessarily seeing the slides. The other things are kind of animated, and I'd like to go back to that. So now, the original classification and definitions of hepatorenal syndrome were made in basically in 1978 at Sassari, which is a place in Italy. And those are typically the criteria that everybody still uses today. And you'll recall it's oliguric acute renal failure, creatinine greater than 2.5 for type 2, greater than 1.5 for type 1, urine sodium less than 10, etc., evidence of intact tubular function, right? Is everybody with me on this? So those are the criteria. So those are from 1978. So it turns out that those criteria are almost impossible to follow. And actually, I did a study at the University of Iowa. We looked at 156 patients who had, actually, I'm just going to move to the, get back to that, sorry. So I did a study of 156 patients who had a diagnosis of hepatorenal syndrome at the University of Iowa. And guess how many of them actually could be diagnosed by criteria? 47%. So less than half of people that are clinically diagnosed with hepatorenal syndrome can actually be defined as having hepatorenal syndrome, simply because there are so many confounding factors. I mean, if they've had a bleed, then you can't call it a hypovolemic. If they've been infected, all those exclusion criteria. So, in fact, this has been a problem all along, and it also is completely out of proportion to what everybody else is saying about acute kidney injury, because we know from the acute kidney AKI and the kidney network, acute kidney injury network, that a creatinine rise of 0.3 is enough to account for almost like a 200% or 300% increase in mortality risk of anybody in hospital. It's a crazy, crazy high risk associated with any really minor acute kidney injury. And this is not liver patients, it's all patients. And so there's no reason to think that hepatorenal, the kidneys would be different. So in fact, there's an 8th International Consensus Conference that looked at this, and they basically concluded that there's a paucity of sufficiently powered randomized trials to be able to guide what to call these things, and to give an evidence base. So they also developed a consensus recommendation. And most of the stuff that we do in kidney disease in liver is in fact consensus-based, which is always, in my opinion, like the last kind of lowest quality of stuff that you can have. So basically the recommendations are not to talk about hepatorenal syndrome anymore, but to talk about hepatorenal disease, and to use the rifle criteria for acute kidney injury. You all know what the rifle criteria are, right? These are pretty standardized. So the rifle criteria then are a rise in creatinine of 0.3 milligrams within 48 hours, or an increase of 150%, or if the urine output's fallen to less than 0.5. And then if it's more severe injury, it's called injury or a failure. So basically it's this over here. The risk is actually what we recognize as being the earliest form. Now the reason for changing hepatorenal syndrome, if you like, to this is that you know for a fact that creatinine in people with liver disease is almost meaningless. It's not quite, but it's almost meaningless because they have no muscle mass, they don't produce creatinine, and so creatinine clearance, in fact the MDRD and all these things that are used for calculating GFRs are completely inaccurate in people with cirrhosis because they have, so in fact it underestimates the degree of renal failure. So if you wait until someone's got a creatinine of 1.5 or 2.5, they've got zero kidney function. They've got like 25 mils per minute or something like that. They're really more advanced than the person who's got otherwise normal function. So that's the reason for going to a more sort of accurate thing, so people can be identified more quickly and get treated more quickly. So this is what they also recommend, is that in people that have no history of kidney disease, they can still get hepatorenal syndrome if they have basically intrinsic or systemic disease leading to kidney dysfunction or functional renal failure. They can get acute kidney injury from all the things that other people get acute kidney injury from, or they can get hepatorenal syndrome type 1, and they still keep, for these purposes, the creatinine at 1.5 for hepatorenal type 2, and hepatorenal type 1 is at 2.5. And then if they've had chronic kidney disease, they can still get superadded hepatorenal problems on top of that. So actually, let me ask you this. Given this, I actually question, does it really matter whether we call something hepatorenal syndrome or not? In other words, if acute kidney disease of any variety gives you such a bad prognosis, and we know from the MEL score that the creatinine is one of the most important predictors of mortality risk. So if that's the case, why don't we just ignore the cause of the renal disease and just get on with just saying any kind of kidney disease and deal with it as we would have to, diagnosing it, correcting it, and using it for prognostic information. So the other question, does it really matter if we call it hepatorenal syndrome? It actually turns out it does. And in a fairly large study of 562 people that were looked at prospectively, they still were calling it renal failure at that time, where they get a creatinine of greater than 1.5. And they divided into 4 different groups. And this in its own right is kind of fraught with difficulties. So exactly how they classify these patients, I think, is problematic. But anyway, they said 46% of the patients got acute kidney injury due to infection, 32% from hypovolemia, 9% from parenchymal nephropathy, and 13% had classical, by definition, hepatorenal syndrome. And what they showed was that the mortality risk was, this is the survival rate, 3 month, this is not mortality, this is survival. 3-month survival was very low in hepatorenal syndrome and associated with infections, but was much better if there's parenchymal kidney disease or if it was purely due to hypovolemia. So the importance of this is that the people that get hepatorenal syndrome, basically there's nothing perfusing the kidneys. And one of the things that's very obvious, and as a cause of that, is that the reason that they don't perfuse their kidneys is because they've got circulatory failure. So the poor kidney, to me, is the canary in the mine. The mine's toxic, the canary dies. In hepatorenal syndrome, the body's toxic, the kidneys die. And so hepatorenal syndrome, where you've got no perfusion of the kidneys and it's purely functional renal failure, the kidneys would be just fine if they were just in a different environment. And that's been proven. Have you seen those crazy studies where they took kidneys from patients dying of liver failure and transplanted them into people that needed kidney transplant, and these kidneys almost universally recovered? I think the original paper in New England was something like 14 or 15 patients. The majority of them recovered. So anyway, the hepatorenal is actually a manifestation of multi-organ failure and acute-on-chronic liver failure. And it results, which is a result of a dysregulated immune response, usually in the setting of sepsis or SIRS. And it's usually secondary to some precipitant with the hemodynamic change, multi-organ failure. And kidney dysfunction is just part of the multi-organ failure. So the non-HRS acute kidney injuries of manifestation of this is not a manifestation of this. Now, the thing that gives this multi-organ failure is called ACLIF, and that's the second topic that I wanted to touch on. So basically, what I've just said about acute kidney injury in cirrhosis, which is all kind of new, and is that the hepatorenal syndrome is a real syndrome, but my synthesis of the data is that the hepatorenal syndrome results from systemic failure, mostly heart failure, high output heart failure, and peripheral vasodilation, so it's circulatory failure. And so, whereas other forms of kidney disease, such as intrinsic kidney disease, somebody gets non-steroidal anti-inflammatory drugs, they have a big bleed, and they get ATN, and so forth, can give you acute kidney injury, which is an intrinsic kidney disease and which needs specific management. Obviously, you can have both, because the person who has a big bleed or gets sepsis is also going to get this ACLIF and eventually get circulatory failure and go into liver failure and so forth. So that's the reason for calling these things hepatorenal disease, trying to distinguish the hepatorenal syndrome, but the hepatorenal syndrome is really a systemic problem that needs to be fixed rather than a pure kidney problem. So the treatment then for hepatorenal disease is to try and prevent it, avoid nonsteroidals, avoid contrast, all the things that give non-HRS hepatorenal disease. And in terms of hepatorenal disease, hepatorenal syndrome, one has to focus on the circulation. So if you can fix the circulation, the kidneys will get better. And that's typically treating whatever caused the precipitant, such as sepsis, if it's alcoholic hepatitis or acute hepatitis, etc., to support the circulation of vasopressors. A lot of people actually turn out to have adrenal failure as well, so it's worthwhile actually looking for that and giving them steroids if they have it. And then renal replacement as a bridge. Now, it turns out that if you give them renal replacement therapy for hepatorenal syndrome, it doesn't actually make any difference in the long run. And that ADQI recommendation was that you shouldn't do dialysis in patients who've got acute have hepatorenal syndrome unless they're going to get a transplant. I don't agree with that, because we have enough reversibility in alcoholic hepatitis and so forth that people do get better and actually recover as well. So it would be condemning a lot of people if we just routinely said no, they can't get dialysis. So the vasoconstrictor drugs, that's the canary in the mine, by the way. So treating hepatorenal syndrome, if you try and treat the kidneys, you're resuscitating the canary. So vasoconstrictor drugs, terlipressin is not available, probably won't become available for some time, but it is the most effective drug, and it's most convenient as well, because you don't need to give it as a continuous infusion. Norepi is just as good, except it has to be given as a continuous infusion. And we've been using midodrine, so typically the person who's not in ICU will get midodrine, or in ICU they'll probably get norepi, usually combined with albumin. Strange enough, transjugular intrahepatic portal-systemic shunts have in several studies been shown to be effective. So tell me, do any of you have concerns about doing a transjugular TIPS in a patient with a high MALD? Yeah, but with we've had this conversation many times before. But anyway, the point is that it turns out that the study that Erin finished actually showed that there's no interaction between MALD and TIPS. It actually turns out that TIPS does not independently increase the risk of death. But a lot of people have concerns about doing TIPS in high MALD patients because they have a very high mortality risk. The reality is people with high MALDs have a high mortality risk anyway, and the TIPS doesn't add to it, but most people don't see that. So, okay, the wrong way. Okay, I'm going to have to go back to some of the other stuff that I was going over. Just sorry about this power interruption, but I wanted to just get back to this. Minimal hepatic encephalopathy we discussed briefly. Just got a few more minutes, just a few other things I'd like to highlight. So I wanted to talk about the liver disease as a procoagulant condition. So people with liver cirrhosis, the most common cause of portal vein thrombosis is in fact cirrhosis. And it turns out that people with cirrhosis actually are more often hypercoagulable than hypocoagulable. And the reason being, if you look at the cascade, all the things that cause anticoagulation are actually diminished in liver disease as well. So in our typical fashion, we measure an INR and we see that the prothrombin time is prolonged, and so we think, oh, they've got to be hypercoagulable, right? Hypercoagulable, they've got to bleed, right? Because we're just looking at one side of the equation. We only see what's in front of us. We don't see all the other stuff that's not in front of us, which is that they don't produce any protein C, protein S. They don't have, and the biggest thing is that they don't produce good levels of antithrombin. They have very low levels of ADAMTS13, and you'll recall that ADAMTS13 is the product that breaks down factor VIII-related antigen components. So the deficiency of ADAMTS13 is what causes TTP, right? You just chew up all your platelets. So they don't have that, and as a result, they are not able to, once they've initiated their clot, they aren't able to stop it, so it just keeps going, and these people actually have been shown epidemiologically to have an increased risk of deep vein thrombosis. Who gives heparin to their liver patients in hospital? I do it routinely because of this, because they have a higher risk of DVT. So the only thing that I would mention is that there's no guarantee that they're not at risk of bleeding, but there's no correlation between the level of the INR and their risk of bleeding. And it's been one of the frustrations over the years is that people will look at the INR and say this person's at risk, whereas they're not. The one way, if you're uncertain, is to get a thromboelastogram, and I'm not sure if that's readily available. It's an old technology. I mean, they were doing it when I was at medical schools. But it's a good technology. It works very well. So the last thing I'm going to talk to is the talk of acute and chronic liver failure. So what's the survey here? This is a really sick liver patient, and you're on this horse and you're trying to get it to stop, and you go, whoa, and almost nothing you can do will stop it. And the reason being, the person's gone over the cliff. So that's kind of what treating acute or chronic liver failure is like. These people are incredibly sick, and there's almost nothing that works to rectify it. It turns out that the primary driver of this is an overactive immune response. Typically, when people have surgery or any kind of trauma or a GI bleed or alcoholic hepatitis, and they release these damage-associated molecular patterns or pathogen-associated molecular patterns which stimulate the innate immune system through the toll-like receptors, and lead to this massive overstimulation of the immune response, which is then associated with acute worsening of the liver disease. And these people look for all the world as if they're septic, but they don't have to be. They can be, but they don't have to be. And you put them on antibiotics, and their temperature stays up, their white count stays up, they have no blood pressure, and so forth. Now, this paper came out this month as well in Gastro, and I think it's a very important paper, although in a way it's got some annoying features about it. But they try to quantify what's going on with this acute on chronic liver failure, and prospectively looked at 1,200 or so patients, and then just followed them. And they defined a threshold of, they just looked at people that had already had one acute decompensation. And remember, I said the decompensation was those four things that I mentioned: ascites, encephalopathy, variceal bleed. And infection was included as one of them as well. They ruled out people with cancer for obvious reasons because they were doing a prospective natural history study. And they showed that this acute and chronic liver failure, when it occurs in that, typically results in multi-organ failure. And they defined liver failure as bilirubin more than 12, renal failure, CNS grade 3 or 4, coagulation factors INR greater than 2.5 or platelets less than 20, any use of pressors for the circulation, and for respiratory, and a PaO2 to FiO2 ratio of less than 200. So you can see there's quite significant organ failures of every variety. And they showed, for example, that in people that don't have ACLIF, they have a pretty good outcome. Even all these people had decompensated disease. This is 28-day mortality and 90-day mortality in dark. But as soon as you had any form of ACLIF, your mortality risk went up massively, and you can see the most severe variety is 90% mortality. So these are really, really sick patients. You can follow here, that what they also show that is very interesting is that the risk of mortality increased the worse the inflammatory response. So the higher the white count, the higher the mortality risk. And very interestingly, people that had no prior acute decompensation, in other words, they'd never had a bleed or an encephalopathy or anything like that, actually did a lot worse once they got this acute injury than people that had. And I don't actually understand that. But I think conceptually this is very important. Well, it's kind of out of order, but that's all I wanted to say, and thank you very much for your attention. I'll be happy to take questions or whatever. Yeah.
So I think I'm one of the internists here. I see a lot of patients with fatty liver and progression to cirrhosis, and I see up to date. I see different indications for biopsy of fatty liver, but I open different books now. So what is the chance of just plain, hepatic steatosis, not even like steatohepatitis or NASH, progression to cirrhosis, and what are the indications or any update on that? To which patients
yes,
should
there are actually good epidemiological data, multiple studies on the natural history of fatty liver. The best data come from the NHANES most recent studies, but essentially about 30 to 40%, in some studies up to 60% of a population can have fatty liver. Something like 10% of that group will have NASH. NASH is defined by inflammation in the liver. NASH, and specifically for NASH, it's the presence of ballooning hepatocytes and then usually neutrophils. Oftentimes there'll be Mallory bodies as well. It turns out that the worse the metabolic syndrome, the more likely they're going to have NASH. So you can predict it to some extent that way. The treatment's pretty much the same. There are attempts afloat at looking at non-invasive markers of fibrosis, none of which are particularly good at the moment, but the most promising is elastance plethysmography, sort of with usually either ultrasound or magnetic resonance imaging, which again may be helpful in determining the person who's got fibrosis. But a platelet count, AST to ALT ratio, and then obviously clinically and radiologically the size of the spleen will give you an indication if they have got cirrhosis, even if they haven't got any decompensation yet.
Dr. Voigt, and a question on the use of lactulose in hepatic encephalopathy. So the benefit is only when you get the patient, I'm also a lay person in cirrhosis. I'm with infectious diseases. So classically, we've been taught, okay, keep the patient having 3 bowel movements a day with the use of lactulose. So I wanted to know if you still titrate them to that goal, or is there any benefit for them to take the lactulose regardless? Do they need to take a fixed dose, or is titrated based on bowel movements?
Yeah, this is a great question. In fact, it's one of my pet peeves, actually. I have plenty, as Jeremy will tell you. So why do we look for a cathartic effect in treating lactose? The concept of getting catharsis for getting rid of ammonia is that the ammonia is in some way produced within the lumen of the gut, and that if you can get rid of the bacteria that are producing the ammonia within the lumen of the gut, then you'll reduce the ammonia production. Turns out that actually the ammonia is not produced in the lumen of the gut. That's a concept that dates back to 1954, and it was relatively soon after that shown that that's not the case, that the predominant ammonia production is actually at the level of the gut wall. And so conceptually trying to give a catharsis doesn't make a lot of sense. It turns out that probably what's happening is the change in gut flora, and giving lactulose sufficient to actually change that may be more important than trying to get the cathartic effect. In fact, if you give too much lactulose and they get dehydrated, you're more likely to cause a problem than fix it. So certainly if there's a lot of protein in the gut, that's the one point where you would actually it does make sense. For example, if they've had a bleed, then you want to try and get rid of that protein. But for the most part, I think titrating and keeping, I personally am very conservative, because there's another downside to giving a lot of lactulose. A person complains of bloating and they diarrhea and they can't leave the house and they actually hate you because you've given them the lactulose. Whereas you give them a little bit, they're actually more willing to take it and they're probably more compliant with using it as well. So does that answer your question?
Sure. So would you use a fixed dose then?
No.
Okay.
Absolutely not. I normally start off with like 10 cc's, 5 cc's a day, literally just about nothing.
Okay.
Yeah.
All right. Yeah. Thank you.
In cirrhotic patients who get hospitalized, we get called about PRN pain medications or opiates or benzodiazepines. Do you have any suggestions? One is better or versus in the opiates or in the benzo group? I mean, I typically tend to prefer fentanyl. I don't know if that's...
Can I ask you, that's a great question as well. So who uses acetaminophen in their liver cirrhotic patients? Yeah, I do. I think it's a great drug. The reason that you can use acetaminophen in liver patients is because the normal metabolism of acetaminophen is by sulfation, and it's a completely innocuous drug. It's only when you go above a threshold of acetaminophen, or if you've had induction of your cytochrome 2E1, CYP2E1, that you'll start producing NAPQ, a NAPQ imine. And that's the toxic metabolite. So in fact, the majority is going this way, and it's completely safe. A little bit goes that way and is toxic. So if you keep the threshold of, let's say, 1,500 milligrams a day for light pain treatment, that's actually probably the safest. If we still had cimetidine, we could give them cimetidine plus acetaminophen, because cimetidine blocks the 2E1. Or if we had some way of giving them an acetylcysteine, but even just not going above a threshold is good. So I typically will say try use local therapy, hot, heat, cold, whatever, if depending what the pain is. Acetaminophen in small doses. If they've got encephalopathy, I try and avoid the narcotics because they tend to aggravate that. And then you can try non-steroidals as well, but you have to watch the kidney function, because the kidneys are typically, once you decompensate, the kidneys vasoconstrict, and to maintain renal perfusion, you have to produce prostaglandin, usually E1, E2, and so forth. So if you're given non-steroidal, you can actually impair that, and your kidney function get worse. And oftentimes, that'll actually make it more difficult for the people to diuresis as well. So you kind of have to choose your poison. But at the end of the day, if people are in pain, you also have to treat that. So oftentimes, you'll end up having to use narcotics. All right. Well, thank you very much for coming. Good seeing you, William. Oh, can I just mention briefly that Doug Lebrecht, and who of you know Doug Lebrecht? He's a hepatologist. He basically started hepatology in Iowa. He retires at the end of this year, and on August 23rd, there's a big conference where we're having these luminaries from around the world coming, Bruce Runyon, Anna Mae Deal, Lofa Misra, these are all massive names in liver coming to Iowa and talking at a conference on the 23rd and 24th. So, and everybody's invited, obviously. It's an open conference, and it'd be a very nice send-off for Doug as well.